Yeah.
You can start, sir.
Okay. Thanks. Hi everyone, welcome to this session and the session on anatomy. I'm Dr. Ankit, anatomy faculty, and today we are going to discuss about the upper limb. Two aspects. One is the osteology, and one is our spotters. Okay, the soft parts, the spotting in our upper limb dissections. So welcome all. Have a look at a few slides about the importance of Auricle. You can see various benefits of Auricle, right from recorded classes to live classes to practical sessions. Benefits of recorded classes over here. You can just take a screenshot and go through it. And same as for the live classes. Express exam module is over here, plus doubt clearing session, hard copy note set, beautifully written over here. Question bank, we also over here with the 3 levels of expertise and beginners to expert level, all the different types of Q bank is over here. Practical sessions also over here, where you can see in this image as madam is showing the skull bone over here with the details of it. And these are the few subscription plans, and you can also use the code Dr. Ankit 20 to avail benefits in any of these subscription plans. We have a basic plan from 19,999 to standard to 34,999. Finally, we have a premium plan of 59,999 over here. You can see the benefits in all these 3 plans. So take a screenshot of this and do go through it in detail, and then apply for whichever plans you want to share. Okay, let's come to the topic over here. So the upper limb is a topic that we want to discuss. Let's go ahead with the topic. I hope you can see the slides over here. Okay, so yeah, upper limb osteology is what we are going to discuss right now, and then we'll come to the soft parts of the dissection images of the upper limb. So upper limb osteology, you can see these 4-5 bones are drawn over here, written over here. Apart from this, let me tell you that in the previous session, we discussed about the radiology part, right? Also the embryology models we have seen few. In radiology details, we have seen the different bones of carpals as well as in lower limb, we have taken the tarsals. Not just that, we have gone through the entire from shoulder to the wrist joint in the radiology. So that also will be supplemented by this particular discussion over here. So here are a few bones, few important bones in the upper limb osteology. You can just remember by looking at the bones, it looks like a dissection or it looks like a viva. When you have that osteology table, no, the bones are placed on the table and you are asked to pick one, or the examiner might him or herself pick one and give it to you. These are the regular normal bones to start with in upper limb, which normally they ask. As we can easily see, and we all should be knowing the names. This is the scapula we can see over here, and there's a clavicle over here. Okay, this is the long bone of the arm, that is a humerus. And these two, one of them is radius, one of them is ulna. This over here is the radius, and this over here, last one is the ulna over here, right? So we'll see these bones in detail and a few important points, how to identify them, then which side are they, because all of these 5 bones you're seeing over here, they can be either of the right side or they can be of the left side. Okay, so therefore the first question that comes to the examiner's mind and which the examiner asks you is, first of all, identify the name of the bone. So that most of the students they identify. Then the next question is which side it is. Is it of right side or is it of left side? Normally, as the protocol of the exam goes, the side of whichever side the bone is, you have to pick the bone onto that hand. Suppose say this scapula over is of the left side, then you will pick it on the left hand side just to show the examiner, okay, that this is the scapula. Then the examiner automatically knows that, yeah, you know it is of the left side. The examiner even then might ask it is of which side, or suppose the scapula is of the right side, as per your knowledge, then you will pick up the scapula in your right hand. Okay, so the examiner knows, okay, he knows the basic protocol of how to pick up the bone and in place it in the anatomical position. And without you saying the side, the examiner knows that, okay, you know it is of which side. He may or may not ask you. Okay, so normal questions which come, let me just write down the questions that, okay, name the bone. Name the bone is first question. If you falter in the name only, then obviously the Viva is not doing very good, and the examiner might ask you to place the bone back on the table and pick any other bone. So the name of the bone is first one. Then, in the case of the arm or leg bones, they will ask you which side it is. Okay, and then you'll tell the right or left, because even we have seen students who have this they uh, just place a guesswork. Okay, right side. Let's suppose it is 50% chance. Then examiner also might ask you, okay, reasons. Why is it of right or why is it of left side? After that, you have named the bone, okay, with side, with the reason. Then comes the question of what are the main attachments, which the examiner might ask you depending on he wants to ask you this or not, or he might come to the next bone as well. So this is a protocol which is followed everywhere. Okay, not just in any particular college or any particular area, but it is followed nearly everywhere. Okay, let us see now one by one. We are not going to just see the slide, we'll go further. So here's the first one, and we can easily identify, okay, it is a clavicle. It is a bone that is the clavicle, right? Then obviously the questions that I said, name the bone, then side and reasons. Okay, now let us see the slide. Okay, these are the questions. How can you determine the side? Let me just highlight the question first of all. How can you determine the side of the clavicle? Because name already have seen, then side, then how. Then import attachments, few attachments that you should know. And finally, clinical aspects. As I always say that clinical aspects are the you can say the not the backbone, but the final result of your knowledge. Okay, not the backbone, but the final result of whatever you are reading, the knowledge. So it comes as a question. Okay. So if you look at a clavicle over here, we'll go through a few important points, not all the points in detail, but yeah, a few important points over here. This clavicle is a horizontal bone, so you don't have to pick it in a vertical position. You have to pick it in a horizontal position. Okay, so first of all, understand it's a horizontal bone. So don't do that blunder to place a clavicle like that in a vertical position. Okay, you have to keep it in a horizontal position. Then easy thing is you can see the two ends, right? One end over here is flattened, and one end is the rounded end. Okay, this rounded end over here, is the one that is medially. It is a sternal end because it is going to form joint with the sternum. Then obviously the other flat end is going to be laterally because it forms a joint with the acromion process of the scapula. Okay, so okay, with this medial, which is lateral. It is a S-shaped bone. As you can see, there are curvatures in this bone like this and like this. And so now the confusion arises, okay, because it can be of left and right both. So you can put it like this also. And if you suppose I place the clavicle like this, okay, middle end I've seen it is rounded, lateral end I'm seeing it is flattened. Then if I move it like this again, so it is of which side? Then we should know that the medial part of the clavicle, it is projecting forward, or we can say it is convex forwards. It is convex forward. Even you can touch your own clavicle because it is a subcutaneous bone. You can feel, okay, it is projecting more forward medially, and as I'm going laterally, then it is pushing back. So this part over here, the lateral part is concave forwards. It is concave forwards. This is must know. Clavicle, let me tell you, in our college, back in our time, is the clavicle was known as a 6-month bone. It was known as a 6-month bone. Why? It was used to be said that if you are not able to identify the clavicle in the side, then then you will be it will be hard for you to pass, and then you have to again reappear after 6 months. So it was famously known as a 6-month bone in our times. Now I don't think now it is like that, but yeah, few places might be. So remember, it is one of the easiest bones, and questions will come. So identify the bone first of all, then side, then reasons, right? Other reason that you might be asked or you should give is that if you look at the shaft, there's a middle part that is a shaft. Then in the shaft, I mean, an image I might not be able to tell you, but let me just try to show you. Over here, you have a groove in the middle. That groove is known as the subclavian groove because the subclavian groove, because the subclavius muscle attaches over here. Now, subclavian groove, sub means below, right? So the subclavian groove will be on the inferior aspect or the inferior surface of the clavicle. Inferior, because subclavian muscle will be below the clavicle. So remember, this has to be on the inferior surface. So name the bone, side, reason, should know which is rounded, flattened, convex forwards or convex backwards, then groove has to be on the inferior aspect. Similarly, if you look at this lateral end, that is a flattened end, on the inferior surface over here, you will encounter few tubercles or few thickenings, irregularities in the bone near the acromion process on the again on the inferior aspect. These will be your conoid part and trapezoid, or conoid tubercle and trapezoid ridge. What are these? These are nothing, although you should know these names: conoid tubercle and trapezoid ridge. These are the attachments of the coracoclavicular ligament. Coracoclavicular ligament. So coracoid process again lies below the clavicle. Okay. So this is enough for you to tell the sites enough. Then about the attachments, obviously, 3-4 muscles that you should know in this particular bone, which will be asked, is major muscles. I'm telling you, one is pectoralis major. You should know. Okay. Second muscle is sternocleidomastoid. Cleido means clavicle. Then deltoid and trapezius. These are the big, you can understand 4 big muscles which are attached onto the clavicle. Okay, so you should at least tell them which is medially, which is laterally. Although deltoid and trapezius, they are found on the lateral aspect, and P major and SCM, they are found on the medial aspect. One anterior, one superior, one anterior, one posterior, like that. So these are the 4 major muscles that you should. So at least these few questions you need to have a good grasp on for you to actually perform decent in your Pythons. Okay, let us see what is written. So, how to determine the side of clavicle? The sternal end is larger and rounded, as you already seen. Sternal is rounded, acromial end is flattened. Important attachments, important muscles. Okay, they are giving you 3 muscles. I include one more. It's trapezius. Ligaments over here again. Clinical aspects again. It is one of the most common bones to be fractured. Then obviously they are going to ask, okay, at which side it is the most common site of it being fractured. Normally it is in the middle part, middle 1/3. But initially few books used to say junction of medial 2/3 and lateral 1/3. But in orthopedics also we read that it is normally in the middle 1/3 where the fractures are most common. Could be slightly more towards the lateral aspect, but yeah, that is right. Fine. So again, here's a beautiful image showing you the right versus left. Okay, right versus left. See over here, medial, take the right side over here and the left side over here. See both their sternal ends. Let me just highlight it. See both their sternal ends and both their acromial ends, which is rounded, one is rounded, one is flattened. Medial 2/3, lateral 2/3, fine. But look at the anterior aspect, it is convex forward, both. And on the lateral side, you can say it is concave forwards. Okay. Then subclavian groove and all will be on the inferior aspect. So I hope clavicle is clear, or this is a must-know bone. Okay, again, what we have just discussed about the subclavian groove over here, inferior aspect, inferior you can see, and conoid tubercle trapezoid line, coracoclavicular ligament, as we have just discussed. Not very difficult. If you just see this bone in images for 2-3 times, you're good to go. Major attachments again: sternocleidomastoid, trapezius, deltoid, and P major. 4 major attachments you should know. Then obviously on the subclavian groove you have a subclavius missile, and then at least we are good to go with this particular bone. Fair enough. Let us see the next bone, that is the scapula. Okay. Again, it is one of the most easier bones to be identified. That yes, scapula. You can see it as a triangular, flat triangular bone. It is a scapula. Simple as that. Okay. Now, if you feel your scapula also in your upper back area, you will feel a projecting bone from the scapula. So on the dorsal aspect of the scapula, you have a spinous process projecting, which continues as the acromion process on the lateral part of shoulder. This is lateral, this is medial, and this is the spine of the scapula, and it continues as the acromion process. Okay, both anteriorly, and this is the same acromion which is going to be forming joint with the clavicle. Now, this is scapula which you're seeing in this image. This is the anterior aspect. Why? Because we are not seeing any spine over here. So this is the from the anterior aspect. This spine which I've said, which you can palpate, this we can say it is a dorsal aspect of scapula. Okay. So scapula identification is easier. Then obviously over here it is going to be articulating with the humerus, head of humerus. So in this area, the scapula will have a concavity again, or a sort of socket which is known as the glenoid cavity. glenoid cavity, as you can see over here as well. So it is present where? On the lateral aspect. On the lateral aspect. And finally, we have this coracoid process also, as you can see over here. This is the coracoid process, atavistic epiphysis. This coracoid process is projecting anteriorly. Okay, try to understand. This image over here, we are looking at, this is the anterior view of the scapula. Obviously, it is of the right scapula. Okay, you can imagine the humerus, which might be coming over here. This is the anterior view of the right scapula. Over here, what I have tried to make is the dorsal or the posterior view, dorsal view again of the right scapula. Okay. So site determination is very, very, very important. Naming, anyone can name. Although out of say 150 or 200 students, 1 or 2 students are those who will find even too difficult to name the bone because of what they haven't read even once, or whatever be the reason. We are not going to the reasons. Fine, but 99.9% students, 99 or 99% students, they name the bone. When it comes to site determination, then from 99%, it goes down to 80-85%, or range from 60 to 80%, 60 to 85%. So you can see, okay, where to fetch marks. So right scapula, this is the anterior view over here, and this is the posterior or dorsal view, because here you are seeing the spine. You'll see other images as well. So side glenoid cavity has to be on the lateral aspect. This is the lateral side over here. This is the medial side over here. Coracoid process is projecting anteriorly, and spine with acromion is coming on the dorsal aspect. Okay. Triangular bone. So here you can see some angles. This is the you can say superior angle. This is the inferior angle. Because see, I'm not going to detail the bone. We have 3 borders, 3 angle, 3 process, so many things in it. But yeah, understand basic things. This is a superior angle over here. This is the inferior angle over here. And this glenoid is said to be the lateral angle. This is at the lateral angle. Okay. Side determination is this. Then let us see some points. How can you determine the side of the scapula bone? Scapula is a triangular shape where there is features such as acromion. It is written over here, and we have gladly bit explained. I hope you understood this. Important attachments, again, see, scapula is a flat bone which has a lot of muscular attachment, Therefore, guys, understand, at any level of your medical journey, medical academic journey, you need to know nearly all the attachments on the scapula, mainly muscular attachments. Because when I'm saying your medical academic journey, I'm going till your PG exams and all. There's a lot of questions come from this particular bone, because there are a lot of important muscles, and obviously there's a lot of clinical applied aspect to it. Okay, so they're not on just 2-3 muscles over here. At least 10-12 muscles you should be knowing. Okay, again, clinical features over here. Okay, here is the another view. So this will be of which side scapula, right or left side? Are you seeing the spine? No, we can't. Okay, so this is the anterior view of the scapula. This this is the anterior view. Now you can just, in your creative mind, you can imagine there's a person standing in front of you, and you are seeing the anterior view of both the right and left scapula. Just imagine someone is standing in front of you, facing you, and you are seeing the skeleton of the person, mainly the 2 scapula. You are seeing the glenoid cavity, so this is on the lateral side, that is on the medial side. So which side scapula will it be? It will be again on the right side, anterior view of the right scapula. I hope you got the point. Side determination is where you have to be 100% sure. Because once you have named the bone and side, normally most of the examiners will pass you. So at least you have passed that important hurdle. Now you'll be scoring marks 6, 7, 8, or 9 out of 10. Okay. So then important parts over here, like say coracoid process, acromion process, superior angle, as I told you, inferior angle, glenoid is like a lateral angle, and obviously this is the medial border, that is the lateral border, that is the superior border. That is common sense. Okay. This whole area over here is known as a subscapular fossa. So which muscle will be attached over here? Needless to say, it will be the subscapularis muscle. The muscle will be subscapularis, right? Okay. Let us see more. These are the few muscle attachments again of the anterior view. We are looking at an anterior view. I hope you are now very much clear of the anterior view. This huge muscle is the subscapularis. Okay. This is very, very important muscle. I am putting a star mark over here. The second next muscle in this view, which is very important, is this huge serratus anterior muscle. It is attached onto the entire medial border. And it actually comes from the upper 8 ribs. 8 ribs. Okay, after 7, 8 ribs. It's a huge muscle, and it is mainly known as the boxer's muscle or punching muscle. So its major action is in punching is major action is pushing the arm or abduction of the scapula. Okay, that is known as protraction of the scapula or abduction of the scapula, mainly pushing punching movements. This is very important muscle, serratus anterior. Then normally in vivas they also ask you, that is actually traditionally a very famous question is, this is the coracoid process tip. What arises from the tip of coracoid process? Mainly two muscles are the short head of biceps and coracobrachialis. Then this was a glenoid. Below glenoid is the infraglenoid tubercle. Here you have a long head of triceps, and from the supraglenoid tubercle you have a long head of biceps. So these biceps are short head. So yeah, there are a lot of important muscles over here. So two important muscles I showed you on the anterior view there. Okay. So again on the dorsal view, okay, not in this image. Let me try to make a dorsal view and some attachments of it. Just it will take around 1 or 2 minutes for you to see the dorsal view main muscle attachments. Although I will advise you to simply go and look and read about this bone, because after clavicle, this is the next most commonly bone that is asked. Okay, this is the dorsal view. Why? Because we have made the spine. On the spine, understand, on the spine, upper border we have the trapezius, and the lower border we have the deltoid muscle. Again, you can understand how important these two muscles are. Same they go for the acromion too. This is the spine, so there's this area above the spine. So here the muscle is supraspinatus. This is the area below the spine. So here the muscle is infraspinatus. Okay. This is the upper angle, and here the muscle is levator scapulae. Below this, we have on the middle border, we have the rhomboidus minor above, and below we have the rhomboidus major. Okay, middle border. On the lateral border, we have the teres minor above. Below, we will have the teres major. These are all important. You can see 7, 8 muscles we have drawn here only, and there are still a few left. Again, if you imagine the glenoid cavity like this, at the above, we have the long head of biceps brachii, and the lower part of glenoid, that is infraglenoid tubercle, we have the long head of triceps brachii. Must know. Okay. Let us now move from scapula again to, let's come to the next bone, that is our humerus. So here is humerus. Easily to identify again. But yeah, if you have not read this bone at all, if you are having a bad day, then you might confuse it with other bones like femur or tibia or radius or ulna. I have seen this trend many times, though rare, but yeah, many times. So humerus over here, how to identify it? Again, the long bone, upper, and here it will have a, you can see the rounded head. This is the rounded head of humerus. So it is present superiorly. Okay. The expanded part below is this the inferior surface or the inferior end of the humerus. One thing. So rounded head, you have seen head will be directing which side. If the glenoid is facing laterally, so head will be facing, common sense, head is going to be facing medially. So this is the medial aspect, this is the lateral aspect. In this image, this is the medial aspect, and this will be the lateral aspect. Understand medial lateral first of all. Again, the same thing. Now, humerus you have identified which side? Because this bone over here can be of both the sides. So look at the lower end of the humerus. If you see a concavity over here, a concavity, this is known as the olecranon fossa. Olecranon fossa, where the olecranon process of the ulna will come and attach in extension of the forearm. A huge hollowness in the lower end of the bone is present, where this fossa will be present posteriorly. So if I say that, okay, here you can see the olecranon fossa, it is present posteriorly, then obviously it is the posterior. This image will be the posterior view of the humerus. Now, again, imagine a person standing in front of you and you are looking at the back of the patient, or the patient is facing opposite. Okay, the person standing in front of you, you are standing behind the person, and you are looking at both the humerus, right and left. Imagine, because you are looking at a posterior view, you are seeing the olecranon process over here. Okay, So now, which side, right or left side? See where the head is facing. Head has to be facing medially. And therefore, this will be of the right side. The right side, posterior view, humerus. Clear? This one should be clear. Then also after that, we have a groove over here, which goes from medial to lateral side. This is known as the very important radial groove, where we have the radial nerve as along with it the profunda brachii vessels. Okay with this. Apart from this, yes, greater tubercle is also an important landmark, but we will see in detail in the upper end. Upper end actually has two tubercles over here. Let me show you that also in this particular image only. This thing over here. This thing is the greater tubercle. Here again, three muscles are attached, which are remembered by the mnemonic SIT. SIT is not any special investigation team, but it is supraspinatus, infraspinatus, and this is teres minor or major. It is minor. And opposite to it, anteriorly, they will have a lesser tubercle where teres major is attached. So let me write that to lesser tubercle, where you have the attachment of, no, not teres major, here you have the subscapularis. The teres major is attached on the bicipital groove, medial aspect. Lesser tubercle will have subscapularis attachment. And these four muscles, I am sure most of you must be knowing, they are the rotator cuff muscles. They are the rotator cuff muscles. Okay, that is a different topic, musculotendinous cuff. Okay. Important attachments, a lot of attachments are over here. We can see in a few upcoming images. Clinical aspects, there are a lot of clinical aspects. Here, this image, head of humerus, medial epicondyle, olecranon fossa. So you can see over here the important things that help us in identifying head of humerus, olecranon fossa. And as you know that the head of humerus is facing which side? It is going to face the medial side. So it is medial side, it is lateral side. And therefore, this is obviously the medial epicondyle, which you can also feel. Where to feel it? On the medial side of the elbow. On the middle side of elbow, if you try to palpate the bony landmarks, you'll feel a projecting bone. That is the middle epicondyle. So yes, this is also projecting more than the lateral epicondyle. So it is easier to identify. So you can just cross. You can just cross, or you can just confirm your knowledge that okay, if I'm saying the head is going medially, and then there should be middle epicondyle also projecting more medially. So that confirms, okay, this is correct. And olecranon fossa on the posterior aspect. So again, this will be the posterior view of which side of the humerus, right or left side. I can imagine if you are facing difficulty, imagine the person standing, okay, yeah, head facing middle, yeah, the right side humerus. Okay, humerus. Did I say the scapula before? No, it is humerus, obviously. Okay, fair enough. So you can see both the anterior posterior view. Try to identify now. Forget what is written, but forget what is labeled in the image. Here, are you seeing any fossa? No, looks like an anterior view. Okay, the head is over here. I'm confirmed the head. Okay, it must be anterior view. Head is facing medially, middle epicondyle. This is the right humerus anterior view. Okay, and again over here, I'm seeing a big olecranon fossa over here. This is the posterior view. Head is facing medially. Again, the right posterior view written, right humerus posterior view. Okay, and here radial groove, as I said, yeah, in some bones it is quite easier recognizable, some bones not that much. Okay, then we also over here have the bicipital groove over here, where three muscles are attached. Latissimus dorsi on one side, pectoralis major laterally, and teres major medially. Okay. Three attachments onto the bicipital groove. Okay, so identify the bone, name and identify. Okay, these are the few landmarks given over here. Then we come to the bone that is the radius. Radius bone is the lateral bone of forearm. It is the lateral bone of forearm. Forearm, we have two bones. One is radius, and on the middle aspect, we have the bone that is ulna. Okay, we have two bones, radius and ulna. Identification of radiuses, it is not as huge as humerus, obviously. You can just look at your own upper limb, look at the arm and forearm, and imagine forearm has two bones. Arm looks huge, it has only one bone. Forearm has two bones. Why? You might, the first thing, in the first day when you enter, okay, you might think of why God has made two bones in the forearm. He or she could have only made one bone. Like there is only one humerus. Why there are two bones? Because what your forearm is doing, the arm cannot do. Like what? Like supination, pronation, this movement. This movement is only possible because of two bones in the forearm. And there are joints between radius and ulna, known as radioulnar joint. doing supination and pronation. Therefore, you need two bones. So there's a reason behind nearly everything in anatomy. Let me tell you this also because I have seen, I have felt, I have heard from a lot of students that anatomy is all about mugging up. No, it is not all about mugging up. It has anyway between 90-95%. There is a reason, a logic, a common sense behind it. Oh, you have to learn it. I'm not saying you don't have to learn it, but obviously, if you understand why it is like this, then it becomes easier and understandable and logical for you to learn and understand anatomy. Even then, you have to do hard work. There is no substitute to hard work. Very good. Now coming back to the bone now. This is the radius over here. And how to identify the radius? Again, not as huge as humerus. One end of the radius will have a disc-shaped structure. This is the head of radius, and it is present at the upper end of the radius. Other end obviously will not have it, but it will be enlarged. So this is the lower end of radius. Lower end of radius. And in this lower end, then let me try to draw over here a head of radius and coming down. Suppose I'm making the right side radius. It is a lateral bone. Lower end will be projecting, and on the outer aspect, that is on the lateral aspect, there will be a styloid process of radius. You can even feel it. You can even feel it. Okay, because this lower end is easily palpable. That is projected outward or laterally. This is the lateral side, that is medial side. So head and lower end expanded with the more expandable lateral aspect which have the styloid process. This is how you can identify the radius. Then if suppose this is radius and I try to draw, okay, here I'm trying to draw, okay, this side. We have the ulna. Ulna will have an expanded upper end and a smaller lower end. So this is radius, this is ulna. Okay. In between both of them, we have a interosseous membrane over here. We have an interosseous membrane over here. Okay. Therefore, interosseous membrane actually will attach to both radius as well as ulna. So these border of radius and ulna, which I'm making with the red lines, these are known as interosseous border. What are they known as? Interosseous border. Why I'm telling you this? Because these interosseous border on both the radius and ulna, they are sharp. So if you start to identify the radius, you will say, okay, upper and lower and fine. Then if you just touch the shaft of the radius or ulna, the moment you feel a sharp border, that border is facing towards the other bone. That will help you in identifying the side of the bone, not the bone. Bone you already have identified, side of the bone. So if you are identifying, suppose in interosseous border in radius, then obviously that border is facing medially, or that is the medial border in radius. And the interosseous border in ulna will be the lateral border in ulna. Okay, let me again tell you over here. Interosseous border in radius is the lateral border, L. Interosseous border in ulna will be the, sorry, that's opposite. In radius, it is the medial border. Okay, facing medially right. In ulna, it is the lateral border. Remember this. It's going to immensely help you in identifying the side of the radius. Attachments come later on, guys. Don't focus. See, there is a sequence, there is a method to read anything, not just anatomy, anything. If you're reading a bone, first of all, identify the bone, the side, why, then main features of this bone, how many tubercles or whatever process they have. Last comes the attachments. So if you have, so if your Viva is reaching the attachments stage, then you know you already have scored around 6-7 minimum marks, and you can only go ahead of it, right? So side determination is very important. So radius we are seeing how to determine the side, radial tuberosity, style process, fair radial tuberosity will understand more. Important attachments, fine. Clinical aspects, there are a lot of clinical aspects. Here comes the image for the major attachments. Okay. Can you identify which bone is where, although it is written right radius ulna from behind? So identify which is radius, which is ulna over here. There's a posterior view. This is the styloid process which I was telling. Okay, this is the head of radius. So this one obviously is the radius. Okay, right radius ulna from behind. This is the lateral aspect. This is medial aspect. This is ulna. This is radius. Behind from posteriorly. Here in radiology also I told you guys. So for those who have heard it already, hear it again. Upper end of ulna is huge, and upper end of radius is huge compared to the other one. I repeat again. Upper end of ulna is huge, and this is the lower end. Lower end of radius is huge. If you see the radius, upper and lower end, the lower end is huge compared to the upper end of radius. In ulna, the upper end is huge compared to the lower end of ulna. Now you might ask, sir, okay, fine, but why do we have to cram this also? You don't need to, because we are over here to tell you a few basic things. Why the lower end of radius is huge? Because it is over here forming the wrist joint. So the forces from the hand go from hand to the radius. Then from radius through the interosseous border, they will go to ulna. Then from ulna, which mainly contributes to the elbow joint, from ulna it will go toward the arm or the humerus. This is how the weight transmission goes. Therefore, you see or you hear a lot of fractures like Montegia's, Galezia's fracture, where you have injury to both radius and ulna. Okay, if you go to orthopedy, sometimes you'll see a both bone fracture forearm. Okay, both bone fracture forearm means fracture both radius and ulna in forearm. Understandable. Okay, so radius ulna, we have seen ulna upper end will have a huge process known as olecranon, and you also have a process like coronoid process and trochlear process like that. So this is the ulna. You can see this is huge upper end. This is the olecranon process over here, and we have a trochlear notch and a trochlear process. This is the lower end of it, smaller, and you can see this projecting part. This is the styloid process of ulna. Styloid process of ulna. Okay, olecranon process, styloid process assistant determining the side. Extra one which I told you, don't forget, look at the interosseous border also. In ulna, that sharp border in the shaft, sharp border is the interosseous border, and that will be facing laterally. So you certainly know which is where. Plus, olecranon process present posteriorly, but in this, you can see this concavity or this notch over here, it faces anteriorly. So you have a process that is going behind, olecranon process that is going behind means posteriorly, and therefore this concavity will be facing anteriorly. This trochlear notch over here. Okay, so your olecranon process, here you have one more process, I guess it is coronoid process, and this is the trochlear notch. Okay, just the names. Let's go through the images and understand the names. So this is about the ulna and attachments. Okay, here is a combined both radius and ulna over here. So here you can see radius ulna. Look at the upper end. Upper end is projecting more above. So this is obviously the ulna over here. That is the radius. And here again, this is the ulna. There's the radius. When you are seeing the anterior view, when you are seeing the posterior view or posterior surface. Look at the lower end of radius. Look at the styloid process and all that. And between them, you have the interosseous membrane. Let me highlight this. This is the interosseous membrane of forearm. And look at the interosseous borders. These are the sharp borders that helps you a lot in identifying the bone, right? So this was about the bones. Let us now look at some soft parts as well. Okay, let us look at some soft parts as well. Just a second. Yeah, here we have. Okay, so dissected specimens of upper limb. Let us see. Let us see how much you can identify. Try to answer on your own. Obviously, I'm here to proceed further. This is the dissected specimen of the upper limb. All the spotters, we have sort of this dissected specimen only, asking you different things. This is spotter number 1, I suppose. Yeah, it is spotter number 1. So here, the arrow, let me place an arrow over here. Suppose the probe of the examiner is over. Just a second. Yeah, the probe of the examiner is over this particular muscle. Examiner asking, what is this? This is a huge muscle. We're looking, first of all, when you look at this dissected specimen, confirm, okay, it is upper limb, not lower limb. Fine. You'll see the fingers and the size, and okay, it is upper limb. Then see which side of upper limb it is. Is it right or left side? So obviously, you can simply look at the thumb. So this is, you can see the left. Okay, you see the left upper limb is over here. This is the left upper limb over here. And this muscle over here is actually the flap which is taken up like this. So this muscle is huge muscle, and that is coming from the anterior surface of the chest. This is this muscle over here is the pectoralis major. This muscle over here is the pectoralis major. So if you once you identify this muscle, again, congrats to you. You will be given, at least I hope you will pass it. Then obviously questions will come. Okay, first question, identify the pin structure. Suppose this P major, I guess yes. Give its nerve supply insertion. So obviously you should be knowing by now if you are reaching the final exams that okay, once the muscle is asked in vivas, The next question obviously will either they will ask the attachments, they will ask the nerve supply, they may ask the actions of this muscle or any other peculiar feature, say clinical feature might be. So these are 3-4 questions which will obviously come. Okay. Now attachments obviously some gross attachment idea you should be sure with that this muscle is coming from which bone. Like for example, PT major is coming from sternum. It has some rib attachments, it has clavicular attachments. Then it is going to humerus. Fine. Then they'll ask you about nerve supply. Okay, or they might ask you directly action also. Nerve supply pectoralis major. Again, they are in every theory book which you pick up or in our notes as well. There are tables given. Okay, over here we will have pectoral nerves. Action is something you should be clear. Here, not much confusion should be there. If you have answered the attachments, then actions you should answer. Because as I've said earlier also, the actions are when a muscle contracts, so whichever joint moves, that is the action of that particular muscle. So in P major, as it is crossing the shoulder joint anteriorly, it is causing few actions like adduction of the arm, then flexion of the arm, medial rotation of the arm. These are the basic actions. Because these things you should know. So identify the muscle, and then the nerve supply is the medial lateral pectoral nerves, and insertion, yes, into the lateral lip, as we discussed, no, bicipital groove in center latissimus dorsi, on the lateral aspect of bicipital groove, P major, on the medial lip of bicipital groove, T major, teres major. Okay, so they also only ask nerve supply and insertion, but I normally ask actions also, because that one should know which actions. Okay, let us see the next quarter over here. Okay, fair enough. So you can see this yellow arrow. Let me put up one more yellow arrow over here. Okay, here it is. Which muscle is this? Again, look at the specimen, upper limb, fine, anterior view, fine, arm, anterior. Which muscle could it be? Okay, it is coming from here up. Okay, it is in the front of arm, huge muscle. It should be biceps brachii. Okay, let's see what they're asking. Pindis structure, muscle, attachment, muscle. So this time they ask the action also. So pindis structure is probably biceps brachii. Yeah, attachments again. Scapula we have seen. Long and short head both. And low down goes into the radial tuberosity. Nerve supply, biceps or all the anti-arm muscles, you should answer. They are our what? They are the musculocutaneous nerve. Okay. And action again, flexion as well as supination. So these are the few things that you should know. Flexion and supination. You might say, okay, sir, this is very tough. See, you have to read it. But while reading, you should know that this muscle is doing this, and you can see it on your own body also. When you are doing this movement, that is this muscle contracting or not, then it will help you. Okay. So first of all, again, in this sort of viva, identification is very important. And nerve supply or action, this thing you should answer. Main muscle, these are main muscles. Okay, let us see the next quarter over here. Okay. Okay, where we have, I guess this is the arrow over here. Okay. So again, upper limb, but this time anterior view or the posterior view. It looks like a posterior lateral view. This looks like a bulk of the shoulder should be deltoid muscle, right? Yeah, it is deltoid. So rounded contour of the shoulder, we all know. Deltoid muscle. See what are the questions will be asked. Again, in any muscle, nerve supply action, attachment, nerve supply action, attachment, clinical importance. Deltoid again, we have seen in clavicle, scapula, both it is coming. In humerus, it inserts. Nerve supply will be which nerve? There is a nerve known as axillary nerve, which actually supplies two main muscles. One is the deltoid and one is your teres minor. Remember this. That will be the nerve supply. Action, mainly abduction, but anterior fibrous flexion, posterior fibrous extension, and clinical importance again. You have the axillary nerve deep to it. So there are a lot of answers for this. Injections we give, iron injections. Okay, so identify deltoid. Let me again show you the image. Deltoid over here. Spot number 4. Okay, over here, where is the arrow? Okay, arrow, I guess, is over here. Yeah, over here. Okay. Okay, so which muscle is this? Okay, let us try to figure out. Again, this is the anterior view of the upper limb, left upper limb. This is the scapula bone over here. And this will be the middle bottom Okay, can you recall we studied there was a huge muscle on the middle border of the scapula, which was coming from the upper atrius. It should be that muscle, serratus anterior. Okay, let us confirm it. Yeah, it is serratus anterior. The other attachment of serratus anterior are the upper atrius. Upper atrius. Okay. So appendix attachment fine. Nerve supply. What will be nerve supply? It is directly long thoracic nerve, also known as the nerve to serratus anterior. Action boxes, pushing, punching. Applied anatomy a lot. Uh, we have paralysis of this particular muscle when there is a long thoracic nerve injury. We have bending of scapula. That is very famous question in itself. It is a short question in itself. Serratus anterior protection, bending of scapula. This is a question in itself. 2 number question comes as a separate question. Bending of scapula. Okay. Fair. Let us see the next spot over here. Okay. Okay. The pin is over here, and we are looking at the dorsal view. This is the posterior aspect of arm. So in the posterior aspect of arm, major muscle is triceps only. Triceps brachii is what we call it. So again, you should know about the 3 heads of triceps: medial, lateral, and a deep head, or medial, lateral, not deep, but yeah, deep medial is a deep one. You can call this as the long head of triceps. So let us erase this deep part over here. Okay. 1 second. Yeah. So 3 heads are medial, lateral, and long head. So 3 head of triceps, where are they coming from? Where do they insert? That is also very important. They actually all go to the olecranon process. So remember, whenever there's a fracture in the olecranon process, then this muscle actually damaged. Other thing that you should know is that this whole muscle is supplied by a very important nerve, radial. Radial nerve is actually the largest branch of brachial plexus. So everything which you are seeing on the posterior aspect, everything in the upper limb which you are seeing on the posterior, all of these muscles are supplied by radial nerve. Not just the muscles, but even the skin over here is supplied by the radial nerve or its branches. Radial nerve. So triceps over here, I've not yet seen the answer. Yeah, triceps it is. And yeah, what are they asking you? Attachment, nerve supply, action. The action again, extension. And 3 heads are over here. Action is extension. Fine. Okay, next spotter over here. Okay, what is the? Okay, very good. Where is the spotter? Let me first show you with a black arrow, 2 black arrows over. Okay, this is forearm, front or back. This is front of forearm, back of forearm. Look at the fingers. Are you seeing the nails? No, it is palmar surface which you're seeing. You're seeing the palmar creases. The creases in the finger. This is anti-aspect of forearm. And here you can see the tendons are retracted and looking at a deep muscle. We are looking at a deep muscle. Okay, where in the anterior aspect of forearm. Okay, so see, there's a saying which goes like, eyes only see what the mind knows. Eyes only see what the mind knows. Okay, so it is one of the deep muscles. Fine. How many deep muscles are there? Flexor digitorum profundus, flexor pollicis longus, and pronator quadratus. These 2 muscles, flexor digitorum profundus and flexor pollicis longus, they are huge muscles and they come as big bulk muscles, and then they distribute tendons and this go into the individual fingers. Pronator quadratus is between radius and ulna. This over here is the pronator quadratus muscle over here, and it is near the lower aspect. So identify the pin structure, give its nerve supply. Again, nerve supplies, it is from yes. Nerve supply over here, the deep muscle supplied by branch of median nerve. Which branch of median nerve? That is your anterior interosseous nerve. Action will be again pronation. Okay, action is simple pronation because the name is pronator quadratus. Let us see few more spotters. Okay, over here. This is interesting. This is interesting. Now, what we are seeing over here is specimen, zoomed in picture showing us what? Showing us the palm. This is what you are looking at, a palm of the hand. But here you are not looking at a tendon, you are looking at some muscle of the palm. Because in palm, what happens? There are a lot of tendons. All the tendons coming from the empty aspect of forearm. All these muscles in the entry aspect of forearm, which are going to fingers, obviously will pass like tendons over here. Apart from the tendons, the palm itself will have few muscles. It is one of those muscles. So here you are looking at these tendons over here. So these are the flexor digitorum tendons, could be profundus or superficialis. And this over here, small muscle, probably could be one of the muscle coming from the tendons. It could be lumbricals. From what we can see, it could be lumbricals, or it could be one of the what we can say, one of the intraosteal deep actually. So this could be either lumbrical muscle or it could be one of the pollicis muscle. But I would still go with the lumbrical muscle, lumbricals. Okay, pollicis muscle are more towards the thumb side, though they can also be here. So let us see what is this. What is pin structure? Yeah, it is a lumbrical. Now, nerve supply of lumbricals are same as that of the flexor digitorum profundus. Why? Because flexor digitorum profundus gives rise to lumbricals. Gives rise to lumbricals. Okay. So FDP gives rise to lumbricals. So the nerve supply of lumbricals is similar to FDP. So FDP, the lateral part is supplied by median nerve branch. So therefore, lumbrical over here is also supplied by median nerve. Action again, action of the lumbrical is pen holding position. Suppose I'm holding the pen. So when I'm holding the pen, what is this action that is being occurring at my joints in the hand? This joint over here between the palm and the finger is metacarpophalangeal joint, knuckles over here. So you can see the flexion of the metacarpophalangeal joint. Second action you're seeing over here is the fingers are straight, fingers are extended. So my interphalangeal joints are extended. So there's extension of, just remember, pen holding position. Pen holding position. Because this is again one of the most commonly asked question for your MBBS journey and post that also, post MBBS also, meaning MCQ entrance, PG entrance. So if you remember pen holding position, then you know the actions of lumbrical. Similarly, over here, I will take this opportunity and tell you that if the lumbricals are paralyzed, then you might have heard of a clinical situation known as clawing of hand. So they might ask you what happens in clawing. Clawing is this. This action is clawing. Now, clawing is just the opposite of the action of lumbrical. So lumbrical, we have flexion of MCP and extension of IP. IP means interphalangeal. In clawing, there's extension of MCP and flexion of IP, just the opposite. So remember, clawing of hand, it is just the opposite of action of lumbricals. Opposite. Okay. Fair enough. Let us see next one. Okay. Fine. So this pin structure, this flag, this pin is into which not particularly muscle, but here they are asking us, can you name this area or this space? For identification of this, you have to look at the specimen carefully. It is not the palm side. This is the thumb, and this is, say, the index finger over here. Okay. This is the dorsal aspect. This aspect is where the pin over here is in this aspect. And if you obviously extend, you see a concavity over here. And what is this? This is a very, very famous question. A lot of times, anatomical snuff box. To be frank, if you want to fare good in exams, you can't afford to miss this topic. As simple as that. Not just your university exam, but one of the favorite topics in upper limb for your FMG, NEET, EG, INICT, name any exam. One of the most commonly asked questions is anatomical snuff box. Boundaries are frequently asked. What are the boundaries? What are the boundaries of anatomical snuff box? Then what are the contents? And what is the applied aspect? And why it is so important? Let me put a star mark over here. The reason is there are a lot of applied aspect over here. You see a lot of tendons over here, and they normally get inflamed with their synovial sheath. That is known as tenosynovitis. This is one of the most common clinical aspect that you normally see. Therefore, this is one of the most common questions asked. There's definitely anatomical snuff box, boundaries. See, they're asking the boundaries and contents. Boundaries and contents. Applied aspect, I already told you, there is a disease known as D. Corvin tenosynovitis. D. Quervans, tenosynovitis, as simple as that. So remember this. Okay, anatomical snuff box, one of the most important questions to be asked. Therefore, I'm showing you this image again. Boundaries, remember. Boundaries are abductor pollicis longus, extensor pollicis brevis, they lie on the lateral aspect. And extensor pollicis longus, it lies on the medial aspect. And main content, only one major content is you have a radial artery over here. Don't try to palpate the radial artery. Radial artery is palpated in front, but then it rotates back and goes into the anatomical snuff box. Okay, the major content is radial artery. I'm sure this is what is written. Yeah, radial artery over here, and these are the boundaries. Anterior, or I told, the lateral boundary, and posterior or the medial boundary. Okay, one more spotter. Okay, now which muscle is this? Which muscle is this? This is again, you're looking at a palmar aspect. This is not lumbrical because it is a deeper muscle in the palmar aspect, and this muscle is probably going towards the thumb aspect. You can see the muscles over here are being retracted. Yes or no? They are removed, and then this is the muscle that has been asked. It is possibly one of the pollex muscle, and the pollex muscle you normally see over here, all the muscles like abductor pollicis, okay, or flexor pollicis, or these two muscles mainly on the side, and also opponents also a bit on the towards the thumb. But there's a muscle known as adductor pollicis, ADD, because it adductor has to move the thumb in this direction. Therefore, the muscle is coming from more medial aspect, from the more palmar surface. This probably adductor pollicis. Yes, it is adductor pollicis. Nerve supply is again very famous question. Is that most of this pollicis muscle, they are supplied by median nerve. This is the exception which is supplied by ulnar, deep branch. Okay, deep branch of ulnar. Yes. One more spotter over here. Okay, what is this? Right. Okay, here we are seeing, maybe they asking, yes, pointer is over here. You see this pointer onto this. So which muscle is this? Fair enough. Good question. Again, sort of we have moved back. Again, we are looking at a dissected specimen of upper limb, anterior view. But here is a muscle, huge muscle, which is actually being cut over here, which is coming from the, you can see the back part, lower back. Inserting into front of humerus over here, this is might be possibly it could be latissimus dorsi. Okay, because it is not coming from the scapula, though latissimus dorsi has one minute attachment on the scapula. But yeah, this is the only muscle. Yes, it is latissimus dorsi over here. So it is a huge muscle. It is cut over here. So obviously a difficult question. But yeah, normally latissimus dorsi is a huge muscle in the lower back. Okay, so that is normally asked when you look at the specimens in the back region. Okay, but latissimus dorsi over here, and insertion of supply action again. You have to do that part. Okay, now let us see a couple of more specimens over here, because we are now moving from muscle to some other structures, some other vascular structures over here. Okay, so here, which structure is this? There's an artery over here. Which artery will be this? You are seeing this as the region of the shoulder region or the scapular region over here. Okay, and in the shoulder or scapular region, only one artery is actually entering into the upper limb, which is continuation of subclavian artery, and that is our axillary artery. So in the axilla, we have the axillary artery, and it actually continues as a brachial artery. Now the question might come, if I'm the examiner, I will definitely ask, where is axillary and where is brachial? Because both are same arteries, not same, but yeah, continuation. So suppose if you look at a map of India, suppose a river is flowing from one state to another state. Say a river is going from Rajasthan to Gujarat. So in Rajasthan, we call it as some other name, river A, and the same river in Gujarat becomes river B. So A and B. Okay. So it is same as this for the artery. In axilla region, we call this artery as axillary artery. The moment it crosses axilla, it becomes brachial artery. So what is that? What is that point where the axillary becomes brachial? It is at the lower border of teres major muscle. Remember this. A lower border of teres major muscle. After this, it becomes brachial artery. So here it is probably looking above the teres major. Could be axillary artery. Let us see. Yeah, it is axillary artery. Which muscle divides it, and the whole anatomy axillary artery, the P minor divides it, continuation, name the branches and all fine. That is the theory part. But yeah, if you identify axillary artery, then you should know few anatomical aspects of it, the branches of it. There are three parts of axillary artery, which muscle divides it, branches, my applied aspect. Yeah, that is all fine. Okay, let us see one more. Okay, this is one more image over here. Okay, what is it? It is again a continuation of axillary, so obviously it is a brachial artery. Simple, yeah. Again, all the question of brachial artery. What is the extent of it? So again, from the lower border TS major, it divides in the cubital fossa or near the head of radius or neck of radius into radial and ulnar artery. So the extent of brachial artery is in the arm only. Therefore, the name is brachial artery because brachium means arm. Understand? The Latin meaning of brachium is arm. And when we say forearm, it is antebrachium. It is antebrachium, which is the forearm. Okay. So it is brachial artery, fine. Okay. Lower border T is major to the level of neck of radius. Continuation of axillary artery that we already discussed. Okay. Okay, one more spotter. Okay, what is this? Again, in the forearm region, we can see a forceps and some tight. If we, yeah, it is looking like continuation of artery only. You look over here, it looks like an artery continuation. More laterally, could if they're asking this, see, be very frank. Once this sort of question is given to you in a viva, what you have to do is, I should have told you before, see muscles you easily identify. Then you see these structures like the vessels over here. You have to touch and feel them, simple as that. And slightly try to roll them, touch, feel, roll them. On rolling, I'm sure you must have seen the simple garden pipe in your home, right? Once the pipe is empty, there's no water, and you roll it. Or even if there is water, you roll it, you will feel that there is some hollowness inside the pipe, a rubber pipe, yes or no? So in rolling this particular structure, if you feel the hollowness inside or you can feel the lumen inside, then obviously it is a vessel. And if there's a lot of elasticity in the vessel, so you have first rolled, palpated and rolled, it is a vessel, and you have seen a lot of elasticity in the vessel, it is obviously an artery. And if there's no elasticity, it is like a paper thin, then it is a vein. Simple as that. Remember this particular thing, I'm repeating it again. You get a cord-like structure in exam, try to touch, feel, and roll it. If you can feel the lumen or hollowness inside, it is a vessel. But in vessel, if you just leave it, it again comes back to its shape and as a thick wall. It is an artery. If it is taper-like, okay, very irregular, then it is a vein. And finally, if you are doing all of this, in the beginning you roll and you don't feel any lumen, it is a nerve then. If it is a solid cord, it is a solid cord like a simple rope. Okay, simple rope. Rope has no lumen. I mean, I'm giving you an example, but obviously the nerves are very thin. But yeah, they won't be having any lumen. It is then it is a nerve. Remember this. Okay, so obviously you can't do this in your screens, but yeah, just going by there, I think it is a radial artery. Yeah, it is a radial artery, but yeah, once you palpate it, then only you will be sure. Don't give you answers like this without just looking from far. Okay, sir, it is artery. In the exam, you have to go near the specimen, wear your gloves. If it is like, what is the rule in your college? Normally, we ask all the students to wear gloves before coming to the viva, particularly for the soft part. And then they ask to feel it. Okay, so then radial artery, now all the branches in the theory part. Okay, a continuation. So it is now on the middle aspect, as you can see, it has to be the ulnar artery. Yeah, it is the real ulnar artery. Yeah, then the branches theory part of it. Okay, let us do the last question of the rest of the spotter over here. So now here it is again a continuation of the arteries in the palm. Can you see this whole area over here? A lot of actually what happens is you have a ulnar artery from here and a radial artery from here. And they will actually go give their branches and they will form the arches. So this is what is known as a arterial palmar arch. And it is present more superficially. So this is superficial palmar arch. Superficial palmar arch. mainly contributed by ulnar artery. It doesn't mean the radial artery doesn't contribute, but it does. But mainly contribution is by the ulnar artery. This is like a yes, it is superficial palmar arch. Okay, mainly contributed by the ulnar artery. So likewise, these we have seen some muscle tendons also, not all but important ones, and some vessels and nerves also. I told you how to identify them separately. Okay. So this is our session, guys. I hope you enjoyed, and any other queries, do let us know. So this was all for the particular session. That's all. Bye bye. Take care, and all the best. Thank you.